Hello and welcome to the Drexel interview. I'm your host, Paula Morantz-Cohen, speaking to you from the university's Picture Gallery. Today our guest is Carol F. Lippa MD, Professor of Neurology and Director of the Memory Disorders Program and Dementia Research Laboratory at the Drexel University College of Medicine. She does basic research on the proteins that contribute to Alzheimer's disease and develops strategies and treatments for prevention and palliation of this devastating disease. Dr. Lippa, Carol, welcome to the Drexel interview.
Thank you. Thank you for inviting me.
Well, you were trained as a neurologist.
That's right.
And that's an area where I suppose many aspects of the brain could be studied, and yet you have focused in on Alzheimer's disease in particular, memory disorders with that particular disease as your focus. Could you tell us why you decided to specialize in that disease?
Well, I had an interest in neurology all along because it seems more complex, it's challenging, and a lot of it relates to the history, the physical examination. Every patient's kind of a different puzzle, and I like the challenge of that. And once I committed to neurology, my interest in Alzheimer's stemmed from a few things. One were the patients that you see in the clinic. I had one during my residency who looked as healthy and bright and vibrant and intact as you do, but when I went to test her memory, she couldn't remember a thing. You could leave the room, come back 2 minutes later, and introduce yourself as a new person. She just couldn't encode any new and complete amnesia. It sort of got me interested in memory.
So that's a very
cognition.
extreme case.
That is an extreme case, but I saw other individuals, and the problem with memory is not at all uncommon, and Alzheimer's is very common. It's increasing as the baby boomers age and all that. And then I did a fellowship year, and during that time, or 2 years, during that time, I studied the biology of the diseases, and it's fascinating, the science of it, what happens in the brain, and so forth. So it's sort of a mix of the clinical interest with the scientific interest. And I'm a physician scientist, so I'm different than most people are either primarily lab people that are in the lab doing things in test tubes or so forth, or they're out seeing patients as a clinician. I really do both.
That is really unusual, and I'm so glad we can talk both about the basic science and we can talk about the more social and psychological elements that people deal with in their daily lives.
Right.
You said that we're seeing more of Alzheimer's disease. Is that true? Is this appearing more, or are we just happening to diagnose it more? Or as you say, is it just an aging population that we're living longer and so we're seeing it more?
Well, there are a couple of aspects to this. One is that there's increasing awareness. People used to just talk, oh, they're getting old, oh, they're getting senile, what do you expect, they're 80, or things like that, and they didn't pay attention to it. Well, now that we have things that we can do to help with the symptoms of the disease, there's more awareness of it. So some of it is just people's realizing that it's never normal to not know where you are or when it is, or things like that. Some of it is also the fact that people are living longer. Now it's an age-related disease. The biggest risk factor is how old you are. And we have better treatments for cancer, diabetes, hypertension, a lot of the things that people used to die from. So people are living older. Plus we have a wave of kind of aging baby boomers, if you will, who are coming into the age of risk, and they're starting to get forgetful, have little senior moments and things. And baby boomers do not accept forgetfulness. They do not want to lose one IQ point, period. It doesn't go with their lifestyle, so they're coming in for assistance at all. So I think overall it's not increasingly common. It's just really a matter of increasing awareness, as well as a larger segment of our total population is in that older range.
Okay, but you mentioned, you mentioned something about getting senile, and my producer and I were talking about that term. We were wondering how you would define, or whether the term is used now, senility, dementia, and then Alzheimer's. What are the differences among those terms? Is senility sort of
that's a
out
great
of
question.
fashion?
It's something that a lot of people don't understand. Senility is out of fashion. We don't really use that. In fact, I've had one Alzheimer's patient at least in her 30s. So you don't have to be like really old to have Alzheimer's.
Unfortunately, yeah.
But also, we don't use the term anymore, really. Dementia is just a kind of a global term for someone who's lost their mental abilities. And, someone who is mentally retarded when they're born and they get older, they don't have dementia, they just are mentally retarded and they're older. Someone who's normal with their thinking, who loses the abilities, and that can be caused by a number of different things. It can be strokes in the brain, it can be caused by Alzheimer's or other kind of cousin conditions, things that are a little bit similar, a little bit different to Alzheimer's disease. So dementia is the big term.
The umbrella term.
Right.
Yeah.
And Alzheimer's disease is the most common subtype that people get as they get
So
older.
Alzheimer's, what's the diagnosis? I mean, how does one diagnose the disease? What are the factors that constitute someone suffering from this disease from a clinical point of view?
Well, first they have to meet criteria for dementia, and that they've lost mental abilities. It has to be bad enough so that it interferes with their daily life, activities of daily living. They now need supervision for things they used to be able to do independently. And it has to involve memory as well as other aspects of thinking or cognition. If you just can't remember, then you have amnesia. So people with Alzheimer's will have language problems. They won't be able to find the correct words. They'll have problems with orientation, sense of direction, visual spatial skills, doing things that should be really automatic to do, planning, organization, mood, behavior, things like that. So if they meet criteria for dementia, and then the onset was very insidious, because if you think of Alzheimer's, it's a loss of brain cells in the memory and thinking areas that's accelerated. So they have to have all that, and it has to be severe enough to affect them. It starts very slowly, and
so it has to be
steadily.
Progressive. I mean,
Alzheimer's is progressive.
It's progressive.
I mean, they can have a good day, they can have a bad day, but when you look at them from year to year, or even a few months apart, they're usually a little bit worse steadily over time without intervention. So you have dementia, and then it's insidious in onset. It's kind of slowly. It can even be difficult to date. I see a lot of patients, and I'll ask them what brings them in, and they'll say their family, there's nothing wrong with them. They don't even see there's anything wrong yet. And then a spouse might say, oh, it's been about 6 months. They really haven't been quite right, slowed down a little, not really doing things. And then a daughter or son may say, well, 2 years they haven't been quite, it's really hard to date.
Subjective.
It's not like a stroke, boom, all of a sudden you have it. It's very slow, and it depends on how good the observer is, and how smart the person is able to compensate they are, and how taxing their day-to-day life is. If you're an airplane pilot or a physician or a professional, then people are going to notice you messing up at an earlier point than someone who puts breakfast on the table every day. So it's kind of complex, but that's the kind of flavor you want to get if you can't really date it, but there's been this insidious decline over time, and it keeps progressing. It's probably Alzheimer's. And then there are mimicker conditions. You can have a vitamin deficiency, thyroid dysfunction, a lot of medical problems that can affect memory and thinking, and so you do blood work to look for those mimicker conditions that have different treatments. And if you rule out those things and you have that kind of a picture, it probably is Alzheimer's.
Okay, well, I want to get into some of the treatments or the strategies that are used, but before we do, the basic science of the disease. We had Craig Venter on this show a few weeks ago, and he spoke about sequencing and the fact that we can now see that certain genes are associated with this disease. Is this the sort of work that you do in the laboratory? Or you work with proteins, don't you, as they relate to Alzheimer's? Could you tell us a little bit about the basic research work you do? Yes,
I do. I don't do the genetic linkage myself. Some of the families that I follow in the clinic, I'll get their blood and I'll send it to other labs that I work collaboratively with, and they do the genetic linkage. But we study we study proteins. Alzheimer's is basically caused by a toxic peptide, like a mini protein called amyloid, and it kills the brain cells in the memory areas first. First, the areas that kind of encode new information, so that the Alzheimer patient can't, remember, 3 words that you give them, or whether they've had lunch or what they had, but they remember their high school and so forth. And then it kind of spreads to other areas. And there are other proteins that go awry in Alzheimer's as well. There's a protein called tau that affects it's kind of a skeleton. It's a protein that keeps the brain cells kind of shape and function intact. It helps with those things. And then we're also studying a growth factor that we think might be important. That's kind of my newest hot thing, that I'm interested in. But basically, in Alzheimer's and in these cousin conditions, related conditions to Alzheimer's, they're all caused by proteins in the brain that aggregate, and something in the process that leads to the aggregation kills the brain cell or keeps it from being able to communicate. We think because there are a lot of brain cells and they all connect and communicate with one another through synapses. They fire in circuits, and that's what allows us to think. And in Alzheimer's, we think the amyloid, this toxic peptide, it renders the brain cell unable to communicate with other cells, and it eventually leads to the death of the brain cell. A lot of the work that we're doing is looking at things that might make the brain cell stronger so it can fight the process, that keeps the things that might keep the synapse, the communicating part of the cell, from getting dysfunctional. I have a PhD working with me, Dr. Yusung Gong, who's looking at vaccines to clear the amyloid out of the brain so you don't get Alzheimer's, or so that it stops, further injury to the brain cells.
So you're actually working on a vaccine for the disease. When would you think? When might you project that such a thing could be possible?
Well, we're in early stages, but there are vaccines. We're actually looking at clinical trials from 2 companies for vaccines, which is a nice thought. I mean, can you imagine that? You get your flu vaccine, you get your Alzheimer's vaccine, and you don't get the disease. Or even maybe someday your children, they'll get their measles, mumps, and rubella, they'll get their Alzheimer's. Well, it'll be eradicated. So it's very exciting, but basically, the concept is that this toxic substance, amyloid, causes the disease, and we argue in the nitty-gritty on exactly how, but the vaccines clear the toxic substance out of the brain. And there are pharmaceutical companies now that have human clinical trials going.
Now, what about treatment in the present state of things?
Sure.
Is there anything that you have in the works, or actually soon to be available, that you can tell us about?
If there's nothing that will cure the disease at this point or prevent it with certainty, but if you focus on what you can fix, sometimes there's a lot. We have several symptomatic treatments for Alzheimer's for the memory loss. They don't get rid of the amyloid from the brain that causes the disease, but in the course of the disease, there are chemical changes in the brain that worsen the problems with memory and thinking. And we have several medicines now that are FDA approved. They're not experimental for Alzheimer's disease, and that we can really use them in all stages. The person who's just starting to slip to the person who has to be carried and can't even talk. They're so severely affected. And they can help symptomatically. They can help attention and focus so that, the person, if they can stay on track, they can help compensate for the memory loss. They help the memory loss a little bit, and it kind of buys people a year or so. So that does a lot. And then we have medicines for the behavioral. For a lot of people, if you thought you were getting Alzheimer's, you'd get depressed, and the depression areas are affected. They get the amyloid as well. So people can get depressed or mood changes. They can lose interest, get apathetic and things in relation to having the disease.